Hello, my name is Jacques Creteur. I'm the head of the Department of Intensive Care in Erasmus University Hospital in Brussels, and I will present you a talk about tissue perfusion. I have no conflict of interest to declare concerning this presentation. The goal of resuscitation are to restore adequate flow and pressure. The idea behind restoration of adequate flow and pressure is to restore and or improve tissue perfusion. We all agree that in a stable shock, there are severe tissue hyperperfusion. The problem is that after resuscitation, when the patient reach, let's say, a stabilized shock by the correction of systemic hemodynamic variables, in this situation, in some patients, there is the persistence of tissue hypoperfusion. And it has been well demonstrated 20 years ago by Daniel De Backer. He was able to show that in patients in sepsis and septic shock, the great majority of those patients present a decrease in the percentage of well-perfused capillaries after stabilization of their hemodynamic status. As you can see here, the SpO2 was around 70%, and despite this correction of systemic hemodynamic variables, there was a profound tissue hypoperfusion in those patients. So monitoring tissue perfusion might be in this context of interest to ensure that improvement of the macrocirculation really results in improvement of tissue perfusion. And the problem in critically ill patients is that this is clearly not always the case. And it has been developed in a concept that can initiate name the loss of hemodynamic coherence, so loss of hemodynamic coherence between micro and macro circulation. To illustrate this concept, you can look at this study performed by Hernandez, including 20 septic shock patients. The authors here gave the butamine to a fixed dose of 5 micrograms per kilo per minute to those patients. The infusion of the butamine resulted in an increase in 15% of cardiac index, but this increase in cardiac index did not result in an improvement of tissue perfusion. As you can see, the perfused vessel density, the proportion of perfused microvessels, and microvascular flow index remains unchanged despite the increase in cardiac index. Daniel De Backer also studied the correlation between change in cardiac index by the infusion of the butamine against a change in the proportion of perfused capillaries. As you can see on these slides, there was no relationship between change in the proportion of perfused capillaries, meaning change in tissue perfusion, and change in cardiac index. Another illustration of this concept of loss of hemodynamic coherence is illustrated here by Dubin and co-workers. You can see here the idea was to try to improve the tissue perfusion by increasing mean arterial pressure by giving more norepinephrine. And again, you can see that in the vast majority of those patients, there was no change in tissue perfusion. In some patients, there was an improvement, but in other patients, there was a deterioration of tissue perfusion. All of those studies have been performed using side-stream dark field imaging, but we have to know and we have to confess that this is clearly a tool, a research tool. This is very difficult to use this kind of monitoring at the bedside routinely. So let me introduce you another monitoring tissue perfusion technique, which is the tissue CO2 monitoring that has been developed for gastric tonometry. And after that, a few years later, with sublingual capnometry. The concept is very simple. Tissue CO2 will increase, first, if arterial PCO2 increase. Second, if CO2 production is increased, meaning an increase in tissue metabolism. And finally, if the flow passing through the organ decrease, resulting in a decrease in CO2 clearance. So in this context, the tissue CO2 gradients that can be defined by the difference between tissue CO2 and arterial CO2 will be a very, very good indicator of the adequacy of oxygen delivery to metabolism. Any increase in tissue CO2 gradient means that the flow is not adapted to the metabolism. We were 15 years ago the first to study the link between the increase in tissue CO2 measured under the tank and the microcirculatory alteration in septic patients. And microcirculatory alteration were here studied using the SDF imaging device. We were able to show that there was a nice correlation between the percentage of well-perfused capillaries and the CO2 gap. When the tissue was perfused, the CO2 gap was low, but when the tissue was badly perfused, the CO2 gap increased. When we gave the butamine to those patients, the infusion of the butamine resulted in improvement of tissue perfusion, and this improvement of tissue perfusion was accompanied by a decrease in a CO2 gap. So we go now from sublingual capnometry to buccal capnometry. Sublingual capnometry had the disadvantage to it's not so easy to perform because the movement of the tongue can interfere with the measurements. So it's probably more easy to use buccal capnometry. The device is applied on the mucosa of the internal face of the cheek, and some industry have developed this kind of device, and I hope that in the few next month we will be able to use this kind of monitoring. Another way to approach tissue perfusion monitoring is also the use of monitoring the peripheral perfusion. Peripheral perfusion means skin and muscle vascular beds. Why is it so interesting to monitor peripheral perfusion? Just simply because peripheral perfusion is among the first to deteriorate in circulatory shock and the last to be restored after resuscitation. So exploring peripheral perfusion could help to detect occult tissue hypoperfusion during acute circulatory shock. We can assess peripheral perfusion with some clinical examination of the skin, like CRT, mottling score, skin temperature, or we can use monitoring device in order to assess the perfusion or oxygenation of the skin and muscle. We have developed we have used, in fact, in our department, the skin laser Doppler to assess the peripheral perfusion. So with Dr. Wazinena Mongolpoon, we have studied the evolution of skin blood flow in patients with circulatory shock. This device allowed us to measure skin blood flow at basal temperature, but also this device can heat the skin, and so we can measure the skin blood flow at 37 degrees. So we can also, besides measurement of skin blood flow, we can also assess what we call a thermal challenge test. So this is the delta skin blood flow induced by the increase in temperature against the difference in temperature. The variable is called delta SBF to delta temperature. So we were able to show that day by day in black column, as you can see, survivor increase progressively the skin blood flow, but skin blood flow remain low in non-survivor in gray bars here. It was the same thing with the delta SBF to delta T. You can see that the survivor increased progressively this variable, but this variable remain very low in a patient who will not survive. If you construct a different ROC curve to assess the prediction of ICU mortality according to baseline variables, you can see that the best predictor for ICU mortality were delta SBF to delta temperature and skin blood flow at baseline. We have also, by using the same device, studied the effect of fluid removal on peripheral perfusion and here on skin blood flow. The idea is that we know that during the fourth phase of the management of circulatory shock, the fourth phase is de-escalation. The patient is stabilized, weaned from vasoactive agent, and during this phase, we try to achieve a negative fluid balance. The risk, of course, here is to induce hypovolemia. So our hypothesis is that by using monitoring of skin blood flow, we can detect tissue hypoperfusion before the occurrence of tissue hypoperfusion, and this was done during fluid removal with a hemofiltration device. So the idea was to measure skin blood flow at baseline before starting fluid removal, after 1 hour, 3 hours, and 6 hours of hemofiltration. Tissue hypoperfusion were here defined as an increase of more than 10% of lactate concentration during the hemofiltration process. As you can see here in white columns, you have patients in which lactate remains stable, or lactate didn't change by more than 10%. You can see that in patients in which some degree of hyperperfusion occur, the skin blood flow decrease even after 1 hour of fluid removal by the hemofiltration device. And again, here, if you construct a ROC curve in order to predict an increase in lactate of more than 10% during fluid removal with hemofiltration, you can see that the best predictor to predict the occurrence of tissue hypoperfusion were not SVO2 or lactate, but the delta SBF, so the decrease in skin blood flow induced by hemofiltration and fluid removal after 1 hour, or the skin blood flow even before starting the hemofiltration. Finally, can this monitoring of peripheral perfusion help and guide the resuscitation? So this is a study published by Hernandez in the JAMA 1 year ago, and basically they compare a strategy based on normalizing the capillary fill time against a strategy in which they try to normalize or decrease lactate level. We know that this is considered as a negative study, but as you can see, when you see the difference in outcome, the difference in death at 28 days, almost reach the statistic significance in favor of peripheral perfusion target resuscitation. And on the other hand, peripheral perfusion target resuscitation results in less organ failure. So in conclusion, tissue perfusion alteration are commonly observed in patients with severe septic shock. We know that the persistence of tissue perfusion alteration is associated with a poor outcome. These alterations are, in some cases, independent of systemic variable and are very difficult to be detected using the classical systemic hemodynamic monitoring device. Tissue perfusion monitoring could be used first to identify patients with persistent alteration in tissue perfusion, and secondly, to ensure that an improvement of the macrocirculation really results in an improvement of tissue perfusion. And finally, of course, the impact of tissue perfusion targeted resuscitation on survival of critically ill patients needs, yes, to be investigated. Thank you very much for your attention.